Welcome to the Commission's panel discussion on how to promote good mental health for infants and children. I'm Penny Armytage, the Chair of the Royal Commission into Victoria's mental health system. I'm joined by my fellow commissioners, Professor Allan Fels, Dr. Alex Cockram and Professor Bernadette McSherry. On behalf of the Commission, I acknowledge the traditional owners of the lands on which we meet and I pay my respects to their elders, past, present and emerging. Before we commence, I would like to thank Professor David Coghill, Professor Harriet Hiscock and Professor Louise Newman for taking the time to participate in today's panel. I know a considerable amount of effort has gone into the development of your witness statements and into the preparations for today's discussions. We are particularly mindful of the time you have afforded us in the context of the current pandemic. These panels are an opportunity to discuss and contest ideas in an interactive way. One of the most powerful aspects of our work so far has been engaging with people and evidence in an interactive way through avenues such as our community consultations and our 2019 public hearings. In our current environment, we're continuing to creatively engage with people to ensure that this is not lost, particularly with people with lived experience. Today's discussion will focus on infant and child mental health, including an examination of current service responses in both the mental health and broader social services sectors, along with ideas for reform and examples of evidence-based and effective practices. We have chosen to convene a panel on this particular topic given its complexity, unique challenges and opportunities, and intersections with areas that extend beyond the mental health system. We know that this life stage has considerable bearing on an individual's opportunity to experience good mental health throughout their lives. But for a multitude of reasons, we have also heard that poor mental health in infants and children may go unrecognised. Whilst this may be reflective of service capacity, it also points to the mental health literacy of parents, families and people working in universal services, along with stigma and a raft of other issues which we will discuss today. For those who do seek help, we have been told about how services often do not meet the needs of infants and children and their families. One parent, Erin, reflected on the inpatient unit her young child Matthew was admitted to, saying that the inpatient unit felt like a horrible place and its look made me feel terrible. As soon as I walked in there, I had a feeling of fear. We felt like there was a big black box that we were shoved in to be processed without any consideration about the individuals involved. Nothing was tailored about our treatment. Of course, we know that there are many tireless, dedicated and kind professionals keeping this system afloat and seeking to improve, if not at the least, the three experts of you who are joining us here today. We will be convening a separate panel on youth mental health, accounting for the different contexts, experiences, challenges and service responses between infants and child mental health compared with youth mental health, a theme we will no doubt explore further today. I and my fellow commissioners have read with keen interest your respective witness statements, and it is evident that you bring a wealth of experience and expertise to this topic, along with thoughtful and progressive reform ideas. Across your statements, there are areas of agreement. Broadly, the importance of recognising risk factors early in an infant and child's life, the integral role of social services in early identification and intervention, and the critical role of parents, carers and the broader families. But there are also points of difference, and I was interested to read the varying emphases that you put forward in your reform ideas and the local and international examples of effective practice you referenced. The purpose of today is to contest your ideas, highlight firm areas of agreement and expand on areas of reform you propose in your witness statements. I and my fellow commissioners will largely play a listening role today, and Senior Counsel Assisting Stephen O'Meara QC will facilitate the discussion. Before I hand over to Stephen to outline the logistics and parameters of today's panel discussion, I would like to once again thank you for your time in assisting the Commission with its deliberations. Finally, I will leave you with the words of Erin and her reflections on trying to seek support for her young son. We felt hopeless and angry. We could not believe that this was the best that could be done. We couldn't believe how peripheral Matthew seemed to be to the process. The services just continued doing their thing, regardless of whether or not it was helping him. We look forward to a robust and constructive panel discussion this afternoon. Thank you, Stephen.
Thank you, Chair. May I commence by thanking you, Chair, for your introductory remarks, and I'd like to thank the Royal Commissioners and the Commission staff for identifying the very important topic, the subject of today's panel discussion, which is entitled Supporting the Next Generation Through Good Infant and Child Mental Health. Today's topic grasps the critical importance of supporting the mental health of those who are presently infants and children in order that they and the entire community may reap the benefits now and into the future. I should, in broad terms, introduce some of the issues that are likely to arise for consideration of today's panel members, namely the issue of identifying infants and children at risk of mental illness and the kind of supports that should be made available to them, the specialist expertise that may or should be made available to service providers supporting infants and children and their families and carers, how the system of mental health and other social services may be organised so as best to address the mental health needs of infants and children, whether there can or should be streaming of care of infants and children within the system, and if so, how, whether the engagement of families and carers of infants and children is important, if so, how that can be best facilitated, and finally, the future requirements of the mental health workforce. I should now briefly introduce our panel members and commence by thanking them again and in advance for their time, enthusiasm and generosity. Without the contributions of witnesses and all of today's panel members, the work of the Royal Commission couldn't practically progress. In no particular order, our first panel member is Professor Harriet Hiscock. Professor Hiscock qualified as a paediatrician in 2000. She works at the Royal Children's Hospital Centre of Community Child Health. She's the group leader of health service at the Murdoch Children's Research Institute. She's currently leading the Centre of Research Excellence in Childhood Adversity and Mental Health. She has many other qualifications which will be evident in her witness statement, which will come to be posted on the Commission's website in due course. The same is true for all of our other panel members, the second of whom is Professor Louise Newman AM. Professor Newman's a Professor of Psychiatry at the University of Melbourne and a practising perinatal and infant clinician. In 2011, she was made a member of the Order of Australia for services to medicine in the fields of perinatal, child and adolescent mental health, education, and as an advocate for refugees and asylum seekers. Our final panel member is Professor David Coghill. Professor Coghill trained and practised extensively in the United Kingdom, and it's been our privilege to have had him here in Australia for the last 4 years. He's employed by the University of Melbourne and the Royal Children's Hospital. He's the Financial Markets Foundation Chair of Developmental Mental Health in the Departments of Paediatrics and Psychiatry at the University of Melbourne. At the Royal Children's Hospital, he's a Professor of Child and Adolescent Psychiatry and a Consultant Psychiatrist in the Department of Mental Health. As if he isn't involved in enough, he's also involved in research at the Murdoch Children's Research Institute. On behalf of the Commission, may I extend a warm welcome to each of our panel members today. Each of our panel will now confirm that they'll be giving evidence today as if we'd been assembled at a hearing face-to-face. And I might start first with Professor Hiscock, if you could confirm that.
Yes, I confirm that, Stephen.
Thank you. And Professor Newman?
Yes, I confirm.
And Professor Coghill?
Yes, I confirm that.
Thank you all. To deal with, and the Chair's already referred to areas of identified agreement with you, and to make it clear for the purposes of this hearing, there was a witness and panel member conclave some time ago, and in the course of that conclave, the three of you broadly agreed, and as the Chair identified relatively firmly, upon some particular observations and principles. And I might read them out in order that they are just established as areas of agreement. And I'll read out a few of them at a time and then ask one of you to confirm as the case may be. The first three are these: that there's been a lack of overall leadership and strategic thinking to date in respect to the system of mental health pertaining to infants and children. Secondly, that there's been an underestimated investment in the workforce and support for the mental health of infants and children, and such services as there presently are tend to be siloed in the sense that they're insufficiently integrated with other areas of the system, or for that matter outside the mental health system. In this sense, and this is the third point, there has to date been insufficient prioritisation given to the mental health of infants and children. And I might just ask for the confirmation concerning those three matters from Professor Hiscock.
Yes, I confirm that we've agreed upon that.
And then the next group of areas of agreement are that, fourthly, if you like, that there's presently no Australian evidence-based guidelines for the prevention and treatment of mental illness in infants and children. There are some international guidelines that could be adapted for the Australian context. The next is that there's presently a deficiency in the education and training of the health workforce in respect to the mental health of infants and children. The next is that there's a significant actual need for mental health support to or treatment of infants and children that's presently poorly served. The next is that it's necessary to develop and provide evidence-based care. And the next is that there's a need to identify and intervene early in the mental health care of infants and children. And I might ask perhaps Professor Newman if you could confirm those.
Yes, I confirm those.
Thank you. And then lastly, and then I'll come to you for these, Professor Coghill, but the third last is that the health, allied health and non-health workforce relating with infants and children requires specialist support for the identification and treatment of mental health. The second last is that it's necessary to develop evidence-based guidelines for the prevention and treatment of mental illness in infants and children. And the final area of agreement is that in order for such guidelines to operate, there must be clinical pathways established for prevention and treatment. And this time I'll come to you, Professor Coghill.
Yes, I agree. We agreed on these.
Thank you very much. That brings us there to the discussion of a number of the issues that were identified in your very invigorating conclave that I've referred to earlier. I might start perhaps with one area that came up several times in the course of that discussion, and that is what the risk factors that can affect the mental health of infants and children. And in the context of that, there was reference both to areas of genetics and to social determinants. And in order that we can really establish these early on, perhaps I could ask, if I could ask you, Professor Coghill, just to identify what those social determinants are that can bear upon infants and children before we get to who infants and children are.
Yeah, I mean, there are many factors, many social determinants of health that really impact not just on the prevalence, but on the severity and the impact of mental health disorders in infants and children. And in no particular order, I would list these as poverty, living away from home, so children who are received into care, being Aboriginal or Torres Strait Islander, all other forms of marginalisation, whether it be by culture, ethnicity, colour, sexuality, and or language. Those who are or have suffered from abuse, neglect, or other significant traumas. Those with refugee backgrounds. And these are the more social side. There are other factors. Would you like me to go on with those, Stephen?
Certainly, go for it.
Yeah, which I see actually as more constitutional. Intellectual impairment, parental mental health problems, obviously an environmental factor for the child, but also an indicator of potential genetic transmission of mental health problems, physical health problems, a family history of mental health problems, and having another mental health disorder yourself increases the likelihood that you will suffer from a subsequent and other mental health problem.
Thank you. In accepting that, and I'll take it that that's broadly an area of agreement, between our expert witnesses today, but that then brings us to an issue about who infants and children are.
So I'd just add parenting as
Certainly.
another very important modifiable risk factor, which I think Dave has, caught up in parent mental health, but the actual parenting style as well.
Yeah, I agree.
Thank you, Professor Hiscock. While I've got you, can I ask you to address the question of who or what, if you like, infants and children are? Because there's something of a definitional debate. Can you start by addressing that definitional debate, if you might, and tell us whether it really matters?
Sure, and I'm sure Professor Newman will have expertise here to contribute, but infants would broadly say from birth to the first year of life, but also recognising that there are antecedents of infant mental health that begin in pregnancy between the mother and the father. So really up to the first year of life for infants, and then children certainly goes up to, depending on your definition, up to the end of primary school is a very practical definition, maybe 12 or 13 years of age, although some of our colleagues in youth mental health would say that adolescence begins around 10 years of age. But I think of youth as infants and children up to the age of 12 years.
Just before I move from you, Professor Hiscock, and I'll go to Professor Newman in just a moment, but what role and what are the significance of developmental processes in those age ranges that you've referred to? Do they map to what are the developmental processes, and do they map to particular ages, or is it
broadly they do? I mean, obviously development follows a sequence of, an infant's learning to talk and walk and develop social emotional regulation. Attachment to a primary caregiver is incredibly important and protective for their mental health. When we go into the primary school age, think of the toddlers, the tantrums, all of those things that you see, the extreme shyness and inhibition. So again, an infant's learning to work out their own autonomy but needs the caregiver there. Into primary school age, we start to see maybe different things there, issues with forming and maintaining relationships, peers, relationships, the sort of emergence clearly or even earlier of autism spectrum disorder, attention deficit hyperactivity disorder becomes a lot more pronounced in these age groups. And also these children, their frontal lobes are developing, focus, concentration, planning is starting to develop, self-regulation again is emerging in these children. And that's really then taking them up into the end of primary school, where we certainly see children in primary school with signs of anxiety and depression, as well as ADHD being the three most common mental health disorders of this age group.
So children would go up to a developmental period after the age of 12. You're a paediatrician, and paediatricians tend to treat
up to 18 years.
Up to 18.
Yep.
What's the thinking behind that?
I think it's been traditional more than anything. That's how we emerged as a specialty workforce out of the adult workforce. So, legally you became an adult at 18, so we provided care up until that point. That means that paediatricians have a lot of exposure to adolescent youth mental health issues, and that's probably partly behind I know we'll come to this later on, but the streamlining of services by age group. I think there's a danger that if we break it up too much, then we lose that continuity of care for families, and they can disengage with services as they pass from one service to a next based on age, rather than perhaps these developmental processes. So does that answer your question?
That answers my question. Yep. Thank you very much. Professor Newman, can I ask you to address the question of the developmental processes?
Thank you. Look, I think what we've already touched upon is that there's something fundamentally problematic about trying to be too definitive about at what age things occur. From my perspective, it's actually very helpful, as Professor Hiscock was saying, to think more about developmental challenges and processes and what's needed in specific developmental periods to promote healthy psychological and social development. I personally, and this shows us maybe some of the problems, to think that infancy, what I would call an infant, is someone who's older than 12 months. But in the area of infant mental health where I work, people have different views. Some people will say 2 years, 3 years, and some say 4. If you look at mental health services, they're very unclear as well. And there's considerable variation about what constitutes an infant as opposed to early childhood. If we move away from that and think about developmental processes, I think that that's really much more helpful, because we can think then about in utero development and prenatal risk factors, such as having a parent who has high levels of stress is a risk factor for the developing fetus. We know that having parents with a lot of their own mental health problems, substance abuse issues, women exposed to domestic violence during pregnancy, all these factors contribute to neurological and ultimate psychosocial development of that infant in their particular family context. If we break it down maybe and think about developmental processes as those tasks and organisational things that need to happen during particular periods, I think it's much more helpful. So for example, infancy, no matter when we have an arbitrary cut-off point, is a period of a child developing neurologically, biologically and psychosocially some core things that are needed for later mental health. That's probably, from my perspective, a very important point when we think about intervention and prevention and better identification of risk. So are there factors contributing to or derailing that child's progress in terms of developing a sense of who they are, so a sense of identity, understanding relationships and how relationships work, beginning to understand how to regulate their own emotions and behaviour, and so on. All of those things are fundamental in the first few years of life. We then see transitions, which might be the development of peer relationships in a slightly older child, as Professor Hiscock mentioned, all very important. And we can see children in that age, maybe the preschool period, already showing some signs of difficulty if they've had a range of risk factors in terms of their functioning. Developmental processes, I think, don't just stop in childhood. So for many of us, it's important to have a lifespan perspective on what development is. Unfortunately, humans get lots of opportunities for developmental repair, even if some things have been detrimental or difficult early on. So we think about major challenges. Adolescence, obviously hugely significant in terms of forming relationships outside of the immediate family, self-identity, and again a whole range of challenges for adolescents and young people, merging into young adulthood and so on. So we have these very important developmental challenges and periods, as opposed to saying, well, if you haven't done this by 18, I'm sorry, even though I might be able to help you, you need to move on to another service. Or this rather reductionist argument about, well, if you turn 11 or 12, depending on definition, service X won't see you, but service Y will. And there's a big difference between someone who has major challenges who might be 12 or 13 in terms of someone who's 18 or 19 who has very different options. So I think in a nutshell, that's why I argue for the importance of having a developmental framework as an overarching way of thinking about the needs of children, young people and families, as opposed to a siloing or a potential fragmenting of our services and responses by having artificial distinctions and breaking everything down into rigid categories. On the other hand, that being said, I think the complexity that we all struggle with is that there are some specific things that a young infant needs and certain developmental problems that a young infant can have that not all clinicians are necessarily going to be trained in. So we still need to look at, even in this developmental framework, what's actually needed in terms of skills and understanding to work at different age ranges with different developmental challenges. So I don't expect everyone to be able to see, as I do in my work, a 4-week infant, and to be able to say that that infant shows some developmental difficulties even at very early age, or those parents are struggling in their capacity to manage and regulate a young baby, for example. So there are some specialist sort of skills that are necessary, but I think what all the child and adolescent mental health system requires is that developmental framework.
Thank you. Before I go to Professor Coghill, might I just ask Professor Newman, what's the practical consequence of developmental periods that you've identified in terms of how you go about providing support to clients in those developmental spaces? Does it impact upon the kind of supports that they need? Does it impact upon the particular learnings and skills that the workforce who service those clients might need to have, and for that matter, the families? What's the practical consequences as you see it?
Well, the practicalities are very complex because of the complexity, and some would say a bit of a maybe fragmentation of the system that surrounds children and families at different stages. So, for example, I might see women with mental health problems and other risk factors in pregnancy. And on the basis of their experiences and the issues facing them, I might be able to raise concerns about them and want to coordinate better support for them during pregnancy, the early perinatal period, and then we have the challenge of looking at follow-up for their infants and so on. So a lot of this depends on point of entry into the system, and parts of the system maybe vary in terms of their expertise and understanding. So, for example, in a maternity setting, a focus might be on healthy pregnancy, have the baby in the best way possible, and all of which is absolutely essential. But there's also a need to look at the mothers and families, parents, psychosocial functioning, their parenting, any parenting challenges that they might face, particularly parents who might have mental health or other mental health issues or other social risk factors, because we need to be able to think ahead for the child. But that might be, in some maternity settings, not seen as a priority. So I think what we face is these challenges about how do we prioritise parental functioning, attachment between vulnerable parents and families and children, better engagement with very vulnerable population groups and vulnerable families who on the whole are not catered for well, and how do we get these approaches integrated into a system of care much earlier than we're doing now, when there are, from my perspective, real opportunities for better identification of risk, intervention, and importantly, engagement with families who might have vulnerabilities in a way that makes it easier for them to accept help and stay with services. So services need to be more fundamentally respectful of the challenges that many people face in parenting, non-alienating, and addressing anxieties, which are real anxieties that some families face, particularly based on histories of cultural difference, discrimination. We look at, say, just as one example, there are many Aboriginal Torres Strait Islander families who might be very reluctant to engage with some services of early intervention and support for them as parents, which they might feel are really just taking potentially quite a harsh view of their capacity with an aim, risk of child removal and so on. So we really need to, I think, tackle some of those particularly difficult issues. Now, pragmatically, as your question is alluding to, it's very difficult to organise that without a major, from my perspective, reorientation to clinical services, which fundamentally integrates a preventive and early intervention model. And I use those words, as you're no doubt aware, quite contested words. I'm meaning early in life intervention, as opposed to later early intervention or intervention early in the course of illness, all of which is very important. But for this discussion, talking about the earliest intervention that we can do, the earliest identification of risk, how do we have systems of screening and identification that do support people who might wish to discuss vulnerabilities that they have, as opposed to making them feel anxious and alienated by that. On the whole, there are some examples where that's done, but it is an attitudinal issue across the workforce in many ways, and thinking about the best possible system of flagging and identification. And then accessible services which are seen as engaging parents in a real way with trusted multidisciplinary workers. So a lot of work that I mentioned in my statement has been about work with other professional groups who are very important in the lives of infants and families with young children, such as maternal child health nurses, for example, who I think are a very valuable resource in terms of thinking about both identification but also intervention, and could be used more effectively than we have in the past, I would think. Very valuable resource. So I think the bigger picture, and I hope that's clear, is about the challenge of integration, breaking down silos, and then having clinicians who are wanting to and willing to engage in that way with vulnerable families who currently don't fit nicely into particular service blocks as we have them.
Yes, two matters in particular that I'll just come back to you about in a moment, because I'll go to Professor Coghill about the issue of infants and children immediately, but I'll come back to you, Professor Newman, if that's okay, about two things you mentioned, and they are to do with the research concerning prevention, and we'll open also the issue of screening, about which you've all got views. So, Professor Coghill, if I can pass to you at this point, on the question of who infants and children are, you've got experience of how a service has approached that question in Scotland, and you've plainly got your own views as well. What can you tell us about how this is to be approached or should be approached?
Yeah, I think my answer, I guess, reflects in some ways what Harriet, Professor Hiscock was saying, that traditionally child and adolescent mental health looks across the age range from the earliest ages through to at least 18 and possibly further than that. I don't have a strong opinion on what is infancy. I think that Professor Newman's discussion of the developmental tasks of infancy and the processes that we have really help us know that it's very difficult to define anything by actual numbers and age. What we find in development is that children and young people develop at very different rates. And one of the factors that influences that rate of development is the presence or absence both of mental health problems, which can put a pause, if it's an episode of depression, for example, on development, or neurodevelopmental disorders, the broader kind of mental health problems like ADHD and autism. My experience particularly is kids with ADHD, who we know are much slower to attain some of the developmental milestones, if one can call them that, and overcome some of the developmental challenges unless their problems are recognized and particularly well supported. The issue of age and services, I think, again, is an incredibly complex one for which there is no real answer. I think a concrete cutoff saying it's 0 to 12 and 12 to 25 is not sensible, because I think it puts a lot of children and adolescents at disadvantage. We know, for example, that the youth mental health services aren't very experienced or skilled in managing neurodevelopmental disorders. They're much more common practice for both pediatricians and the child part of child psychiatry and mental health. And so, for example, to treat someone for ADHD up until the age of 12 and then hand them over to another service really does that person a disadvantage. Even handing them over later on at 15, and because we struggle to find adult services, actually all of those transitions are problematic for disorders that continue lifelong. However, if you've got services for adolescents that are specially designed and very effective at managing severe depression, for example, and you have a younger child who becomes severely depressed, if it were my child, I'd want them seen by the specialists. I'd want them seen by services that had pathways. So I think there are alternative ways at looking at how we manage development over time. I think the last thing that I would say on that is that development has a different look depending on which viewpoint you take. I think the advantage that pediatricians and child and adolescent psychiatrists have through their training is to be able to look at development from young through to old. One of the problems that we have within our youth mental health services, many of which are actually staffed by adult psychiatrists who have come down the age scale, is that they're often looking at development from above. So they're looking at it from a perspective of understanding adults, but looking back at what would or should be expected in development. And by doing that, you miss an awful lot of the important developmental work that needs to be done. And again, we know that many adolescents with mental health problems really struggle with some of the very basic tasks that you would have expected by their age for them to have managed. And the same goes for the children with neurodevelopmental disorders.
Thank you. Professor Hiscock, have you got anything to add to that general topic before I open up the question of prevention with Professor Newman?
No, look, I think I'm in agreement with David, and we'll get onto it later. I think about models of care whereby specialists can help the primary and secondary care workforces, but I see that as key to increasing the scope of existing workforces in what they do in mild to moderate illness. And then as Professor Coghill, sorry, we know each other well, so I'll revert back to David every now and again, but Professor Coghill was saying is, having those really specialised services for the more severe end of a specific illness makes a lot of sense to me.
Yes, thank you. Professor Newman, what does the research tell us about whether mental illness can be prevented?
It tells us a lot and then very little, to summarise it. It's a really obviously a huge problem that a lot of people and scientific research has been looking at to really try and see, firstly, if it's possible, and secondly, what we base a preventive science on. So the consensus would be that we need to look at what are the earliest risk factors for mental disorder, as we've been discussing, but also which of those risk factors are things we can actually intervene in. So, for example, someone might have a genetic vulnerability to a particular illness. We're not likely at this current stage of knowledge to be able to change their genetic vulnerability, though that might be something in terms of intervention that happens in the future. What we do know about early risk factors for mental disorder, and these have become the main objects of study for prevention, are things like the quality of the child's caretaking relationships, so essentially their attachment relationships, the broad social factors, the significance as a risk factor of early trauma, abuse and maltreatment, however we define that, and particularly what protective factors there might be. So are there other people in that child's environment who might be supportive carers? What's the service response, and so on. So the science has focused in terms of early infancy, however we define it, infancy, early childhood, on this idea of really boosting protective factors in terms of supporting children in their psychosocial development and brain development, often through attachment-based interventions, but also having actual programs which are aimed at reducing risk, particularly severe risk like child abuse and neglect. Now, child abuse and neglect are one of those areas that are highly, it seems to me, it's always puzzling, but it remains a contested area as to who does that work in child abuse and neglect. despite the fact that we know that it's a significant factor in producing and being associated with the entire range of mental disorders diagnostically down the lifespan. It is a huge risk factor, and on that basis should be one of the things that is a focus for services. However, in my experience, there are some mental health services that say, well, that's a matter for child protection services solely, and it's not a mental health issue. That's, I think, a good example of what I mean by a breakdown of a developmental understanding and this siloing and fragmentation of approach. So a lot of the work that I've been involved with and others is really focused on how can we support the development of attachment relationships, how do we support vulnerable carers with a range of risk factors themselves, how do we reduce rates of child abuse and neglect, as well as the basic science work that's gone on about how significant high levels of stress and trauma are in terms of child development at a neurological and biological level. The challenge is how do we have actual support within systems and funding bodies for the implementation of these sorts of programs. There's a reasonable amount of clinical practice and some research about particular programs that might be effective in improving those early parameters of development. That's really difficult to get funding for, but there is some very good work there. The issue is how do we get that translated into service models? And there have been various attempts to do that over the years, but on the whole, what's very concerning, I think, is that we don't have an overall strategy and coordinated response to the prevention of some of the major risk factors that we know about. We tend to maybe wait. Trauma is a very good example. We know that early child abuse and trauma is associated with a range of disorders, but particularly some adolescent presentations who might not go into a trauma-informed service. They might go to another service, and some youth services vary, but some are not particularly trauma aware. They might make other diagnoses, don't take a trauma focus in terms of intervention. So in a sense, a missed opportunity for really stopping a developmental pathway to enduring disorder. The corollary of that is that we also see adults who are survivors of very severe maltreatment and trauma in infancy, largely women, who move between different aspects of the mental health system, who've not had opportunities often for any trauma-focused intervention, let alone prevention. And we know in some cultural groups that that's a major issue. We then, in maternity services and related services, will see that transgenerational impact when people who themselves have experienced high levels of early adversity in their own infancy and childhood attempt to parent the next generation. And that in itself is a major public health and social issue. So I'm using those examples really to make the point, I think, that prevention, there are lots of preventive opportunities. We have some basic understanding of the science. We need a lot more research support to actually look at intervention programs. I particularly advocate for those early parenting programs for very vulnerable parents and population groups, where we know there are risks for that transgenerational transmission of trauma and adversity on the next generation. And with the hope, I guess, and at the moment it would be a hope that if we instituted that on a system-wide basis, we might actually be able to intervene in a preventive way in rates of childhood disorders, but importantly, lifespan trauma-related conditions. So I think there's a gap between what we know and what we do, which is a source of, I think, anxiety for those of us who are working in that field. I think the science is emerging. It's actually maybe not in the terms of longitudinal follow-up studies. It's very difficult to get funding for some of the longitudinal studies, but at least in terms of shorter term intervention, that we can actually improve infant developmental outcomes, parenting quality, even for vulnerable parents, and engage them. I think very appropriately, we need to focus on families' experiences of coming to mental health and parenting services. But until we get that integration, it's going to be very difficult.
Thank you. Can I ask you just one question about care relationships, which you referred to in the course of your answer? One feature of our community is that there's now a lot of non-traditional family arrangements. Is that an area, or what does the research tell us about whether that's an area of vulnerability? You've identified some other areas of vulnerability, but is that something that needs to be approached in any different way in parenting programs, for that matter, or by clinicians once it gets into a clinical setting?
Yes, depending. Look, I think it's a hugely important issue, and one of it's about obviously equality in terms of access to support and services and non-discrimination on the basis of whatever diversity issues we're looking at. In some hospitals, particularly in maternity settings, that's still a problematic issue in some ways. Some of it might be on a clinician level, but the principles of what children need for healthy development and prevention of mental disorder and emotional problems is essentially to support whoever's in a caretaking relationship with that child, in terms of, from very early on, that face-to-face interaction, who helps that child, who supports that child. So parenting programs that I've developed, we've had a variety of carers who come to our programs. Some are not biologically related to the child in any sense. Some are other family members. That varies with culture. We have same-sex relationships. We have some very non-traditional family configurations. And we have consciously decided that that's very important, that services offer that. There was some anxiety amongst some ethics committees that maybe some others in traditional relationships might find that difficult. I haven't found that to be an issue. I think that's an attitudinal issue. I found that most people unite and share the common sort of challenges of early parenting and so on, and want to be there to care for children. The same applies to cultural diversity. I think there are some logistic issues you have to be careful of. So if I learned the hard way by working with some African communities, where I said, well, please, whoever would like who's involved in the care of this child, please come to this particular meeting. And I had about 15 people arrive, because for them, all these people were very important, which was marvellous to see. But it makes, with room sizes and current issues, it was very, very difficult. So I think there's some practicalities, but I think it's absolutely important that we break down this notion that usually the mother, but the biological parent has the sole right to treatment.
Thank you. I think all of our theatres and stadia are empty at the moment, so you might find it easier. I tempted you by saying that I was going to ask you about the question of screening, but I might go to Professor Hiscock about that and come back to you if that's okay.
Yes.
Professor Hiscock, Professor Newman's referred to one form of intervention, which is by early parenting programs, and that would be, and I said I'll come back to it and I will, but that would be administered by the clinicians and professionals who are already administering that kind of program. Another area which is covered in the statements of each of you is the value of intervening, or knowing whether to intervene by use of screening. Can I ask you to introduce that topic and ask you to tell us what the pitfalls, or for that matter, benefits of screening are from your perspective?
Sure. So the idea of screening really comes out of physical health conditions rather than mental health conditions. And I prefer the idea of surveillance rather than screening. So the screening says you've got a really good single or very brief measure that you can ask a series of questions to families about their child, or make observations, and on the basis of that you say the child is or is not at risk of developing a mental health problem. Then, so you've got to have a good measure that does that reliably and doesn't give you a whole lot of what we call false positives, so that unnecessary stress happens for the family, or unnecessary resources which has a cost to them are put into that family, or what we call false negatives, saying no, this child's okay, but actually down the track they turn out not to be okay. So you've got to have a good measure, and I don't think we've got a really good measure in infants and young children to really reliably do that at a single point in time. Things change over time, so if you, whatever you do, you can't just do it once and say, that's it, I've sorted out that family. You have to think about ongoing surveillance. Then, of course, you've got to have the resources available to be able to meet the needs of whatever you find. So the worst thing you can do is turn up a number of issues and problems and not be able to address them and say, sorry, we've identified that, but we can't meet your needs for another 12 months because our waiting list is 12 months. So the Young on Wheels criteria, were developed back in 1968, the year of my birth, and there's criteria around understanding when to screen and what you need to have in place. And there's some of the things. You've also got to know the natural history of the underlying condition for which you're screening. So I think we should have rather than screening as one measure at a point in time, we should think about ongoing surveillance of the mental health and wellbeing of infants and children, and that can be done through existing workforces like maternal and child health nurses and GPs and teachers and early childhood educators. And there should be some sort of warning signs that then say, okay, we think this family may need some more help. We need to ask them, do they want that extra help? And then we need to have clearly identified pathways for them to get care and support. And when Professor Newman was talking about parenting programs, which are so important, what we don't do though is really, by and large, a lot of the time, those services don't reach the lower socioeconomic vulnerable families. And I know my colleagues in New South Wales, instead of waiting for families to come into their centre, they go out and do supported playgroups, and they build into those supported playgroups assessments. They work out which kids they're worried about, and they start to deliver the parenting interventions by going out to the population rather than expecting the population to come into us. So I think the concept of ongoing surveillance is a great one. We've got the Strengths and Difficulties questionnaire already embedded into primary school for government schools in Australia, but only at school entry and prep. Can we be doing something before that? And can we be doing something throughout the primary school life, not just have it at prep and go, right, that kid's done and dusted until high school, which is often not the case.
Thank you. Professor Coghill, are there difficulties relating to stigma or trust or any other difficulties that are provoked by the screening question, or for that matter, the application of diagnoses to very young children?
Oh, that's a big question. Yes, there are. Stigma is a huge issue within mental health, but no less an issue within infant and child mental health than it is across the board. When we look at public surveys about mental illness, we see still high levels within our community, not just of stigma, but of fear and misunderstanding. The RCH Child Health Poll looking at child and adolescent mental health showed us that the mental health literacy of parents is still very poor, and a lot of misconceptions and misunderstandings there. But our experience has been that it's not only at the individual and population level, but there's still a lot of stigma within health itself, within social work, within education, and again based often on misunderstandings and misperceptions. In my evidence, I cited an example which, as I said there, unfortunately wasn't an isolated example of an ethics committee asking us to take out the words your child may be suffering from a mental health problem, because it was felt that those words may cause fear, panic, and feelings of stigmatization in the parents that we were asking. What was important about this situation was that these were families who had sought and already been accepted for mental health care for their child. And these kind of institutional aspects of stigmatization are something that come up very frequently. What we do know about screening and screening questionnaires is that asking the question, do you have thoughts of harming yourself? Do you have worries? Is your mood been low? These kind of questions don't induce problems. So asking someone, for example, and it's maybe the most extreme, but have you been feeling suicidal, doesn't increase the risk that that person either will feel suicidal or will act with a suicidal behavior. So screening and asking the questions isn't the issue. Professor Hiscock has really hit the nail on the head, that the problem isn't so much what we call specificity. We have screening questionnaires that are quite specific and pick up most cases, but they're also not, sensitive and pick up most cases, but they're not specific in the term that they often also pick up a lot of false negatives. And that causes problems not just with overdiagnosis, but the potential treatment of children if the subsequent assessment isn't actually of a high quality and relies on the answers to the screening question to say, yes, we've got a case of depression or ADHD or anxiety, then actually treating for something that isn't there or treating the wrong the wrong problems. Actually, the best screens that we have are knowing the right questions. We know that we can assess accurately, sensitively, and specifically childhood mental health problems by asking the right diagnostic questions, the right assessment questions. And the best people to do screening are those people who see the child. And I think here's an education perspective for us, that all of those who are in constant, commonly in contact with children should know how to ask these questions. They should know what to look for from the behaviors, but behaviors on their own aren't often enough to let us know whether something is a problem. They should increase our sensitivity that there might be a problem, but then knowing how to ask the questions. And Professor Hiscock and I often debate this about whether people have time to ask those questions, whether people are given time to ask those questions. And I think that depends on how important you see it as identifying these types of very disabling mental health difficulties that people have. We ask a lot of other questions. We do a lot of physical examinations when we see children within the health setting. Social workers and educationalists ask an awful lot of questions, but making sure that we know and that we can actually take time to understand whether someone has a mental health problem is actually the best screening, as well as, before that, screening for the risk factors. Those social determinants of health that we've talked about are things that we can all recognize and put someone in a higher risk category where we've got to be a bit more sensitive, where we've got to open our eyes a bit more to actually check whether or not someone's suffering from a mental health problem.
Thank you. Is it, does it, oh, I'm sorry.
To add to that, if I may, about the issues of the very young, where making a diagnosis of a baby or a young infant is inherently problematic. And it's not as easy to define disorder. I certainly do not use the language of mental illness about someone who's a month old. Or if,
so certainly I agree with you, Professor Newman, but you also know the right questions to ask to know whether there's a high possibility or probability. And I'm sure when you work with the with the maternal and child health nurses, they also learn that language. They learn how to recognize, not just from the questions, an infant can't answer questions from you, but to be able to look with a trained eye and a trained ear at the signs that it's likely that someone has a mental health problem. If I said disorder, I apologize, but problems that are associated with mental health. So I think that it is possible. If it wasn't possible, we'd all really be struggling. But actually the literacy isn't out there. The understanding isn't out there amongst all of those. I think it's getting better in some in some settings, but not in all, to ask those right questions, be they verbal questions or be they questions of looking and observing. So I wasn't meaning diagnose, I'm meaning identify those who are at high risk, who need to come and see someone like yourself, need to come and see Professor Hiscock, need to come and see me or other mental health specialists.
So our approach in infant work is precisely that we look at, we describe more developmental difficulties and developmental risk, and the ways of questioning around that and screening around that can be quite specific and very useful. So, for example, we do screening for particularly maternal psychological problems like depression in pregnancy. So someone who's going into a maternity service will actually be screened for depression and anxiety, domestic violence, and their history of mental health problems at their first booking in visit in many hospitals currently in Victoria, which is very important. And it immediately helps us be alert to those who might have problems in parenting, or the infant might have problems in terms of their development. The skills that David mentioned, I think, are very important. Observational skills, so maternal child health nurses have excellent observational skills and can pick quite accurately, quite early signs that there may be developmental problems for that child, and they're using routine screening. So I think all those approaches are very helpful in that whole idea of alerting us to those who are already, even at quite an early age, showing developmental problems and problems in emotional and psychological development that can develop into mental disorder.
The one other thing I would like to say, if I can, is I have a difficulty with, we shouldn't identify things unless we've got the capacity to manage them immediately. I think that we have we have treatments that are effective for mental health problems. We don't always have the capacity, and sometimes at the moment people need to wait. I'm uncomfortable though with, in a sense, deliberately not looking for something because I'm worried that the capacity isn't there. I acknowledge that that may be controversial to a degree, but I think that what we need to do is, by increasing our recognition, and let's not be under any misunderstanding, mental health problems in infancy, children and adolescents in Australia are under-recognised, under-diagnosed and under-treated. But I don't think we can be complacent about that just because our services struggle. I think that opportunities like this, that the commissioners are looking at how we can reform, how we can remodel, how we can bolster our services, we need to be truly aware of what the capacity needs are. And it's not just about extra funding, it's about being smarter with the way that we use our resources. It's about being smarter about the ways that we work together. But I think that the argument and that we have a capacity issue, therefore we shouldn't look to uncover again these very disabling conditions, problems and disorders that our children and young people have.
Thank you. Can I ask a follow-up question, Professor Coghill, which is, you've referred to, well, if you go looking for something, you might find it. And if you find it, you might have to do something. And you've said that there are interventions that work, and you've alluded to the possibility that you might be able to use the features of the system that you already have to address them. Can you expand upon that a little bit further to say, and give us the benefit, or the commissioners, the benefit of your ideas about how the system could better be organised to respond to the kind of information that screening might reveal?
Yeah, I think it was acknowledged at the very beginning that what one of the things that we in Victoria and across Australia suffer from in this area is that siloing and fragmentation of services, and that actually leads to a lot of duplication. It leads to a lot of extra work being done, people being reassessed by several different clinicians in several different services to have their problems managed. We also have a lot of clinicians who are working in isolation. Many of our private clinicians, be they medical or psychology or allied health, work independently and therefore can't make use of the multidisciplinary team, and actually the multidisciplinary team in child and adolescent mental health with the flexibility to use team members together and separately to play to their skills is something I think that's very important. We know that most children with mental health problems don't get seen, but also we know that those that are seen under NBS, for example, often receive quite transient care. So only a very small proportion of those with mental health problems who are seen within the MBS funded sector actually receive what we could consider to be minimally adequate treatment, paper that Professor Hiscock and I have just recently published on that. But also, if we look at the publicly funded specialist mental health services, they see a large number of children. It was just under 12,000 within the 2017-18 year. And unlike in the MBS funded services, those 12,000 children were seen on average 30 times each. Now that's a huge amount of time that's being spent. And what I see when I work within a publicly funded mental health service is that a lot of that time was actually spent on case management, on supporting the social and educational needs of those children, rather than actually providing specific evidence-based therapies. And where evidence-based therapies are provided, then again, we often don't measure outcomes. We're not clear. We don't have both an evidence-based and a measurement-based culture that's been very clearly demonstrated across health, including in mental health, and in our own work in Scotland within child and adolescent mental health services, actually at reducing the number of contacts that you need to have with an individual whilst optimizing and improving the outcomes. So there are a lot of missed opportunities in the ways in which we currently work. I think that a key will be bringing together the pediatric workforce who carry out a lot of the mental health work at the moment, and the specialist child and adolescent mental health work. And I'm talking specifically here about children. The same could be said for adolescents. I wouldn't want to comment on how best to organize infant mental health care. Professor Newman understands that much better than me. I think the way that Professor Hiscock and I differ on how we deliver more integrated services is, my experience is that bringing pediatricians, bringing allied health professionals, and actually bringing in primary care and others from the community, bringing them into the child and adolescent specialist mental health space, not subsuming them, but joining them together with that as a focus, is something that can provide more efficient care. I think Professor Hiscock has a different view that I'm sure, whilst we have very similar ideas on the need to integrate, slightly different views on how that should be done. But my view of an infant and child mental health hub would be one that actually conducts the work that's currently carried out within the CAMS and KIM services, but also brings the pediatricians into the tent, into the workforce, and probably primary health as well. I think the one problem with all of this, and this is really, I guess, a governmental issue, both at the state and Commonwealth government, is how this is funded. Because currently, mental health service and pediatric services are funded by completely different streams with completely different emphasis. So bringing them together needs reform, not only in the way that we deliver services, but the way that we reimburse services. I think these are incredibly complex issues. I don't think we can solve them in an afternoon. And my suggestion, which we may come back to, for a for a collaborative centre for infant and child mental health, that's similar to the one the commissioners are proposing for adults, similar to what we have in Origin Youth Health, is where we need to develop and test these ideas out. And then we need to be able to disseminate them, evaluate them, and bring them out into the community. So I think it's a very, very complex question. Obviously, I could talk all afternoon on this, but we need to share the discussion around.
Thank you very much, Professor. You wouldn't be able to do that, because if you did that, you'd be making the same mistake that I made last time we had a panel, where I got so overexcited we forgot to take a break. So we won't be doing that today, because that got me into a lot of trouble. But before we take our break, why don't I let you, Professor Hiscock, identify the areas of discussion and disagreement that there've been between you and Professor Coghill, because we've been so tempted by his identification of the fact that you have slightly different views.
I don't think it's an either or. So I agree with what a lot of Dave is saying. At the moment, only 10% of children according to the Young Minds Matter survey, who met diagnostic criteria for mental health problem between the age of 4 and 17 years, get a CAMS service. So the remaining 90% are seen by the GP, the school counsellor, the paediatrician, or the psychologist. So I am very interested in different models, and I think Dave said we need to develop and test them, because we don't have the evidence, we don't know the answer. There may be a model which brings paediatricians and GPs into CAMS. That may sit alongside a model where we say we can't bring everyone into CAMS because we simply don't have the capacity. So how else do we support our GPs, our maternal and child health nurses, our often private practice psychologists and private practice paediatricians, who are doing the bulk of the mental health care for children, certainly, and for infants, a lot of it. How do we support them do evidence-based care and care that we know can make a difference? And that's, I'm sure we'll talk about after the break, things like tele-mentoring. You know, we've all shifted to telehealth with COVID-19 spectacularly well, not perfectly for everything, but how do we get disciplines together in a tele-mentoring sort of Project Echo type model? And I'm thinking of bringing in social care in our CRE and childhood adversity in Wyndham, and in Marrickville we're going to have GPs, maternal and child health nurses, paediatricians, psychologists, social workers, financial counsellors, and a lawyer, all in the same place. And we're going to look at monthly tele-mentoring support together. With that tele-mentoring actually being available to the childcare centres around the centre, the antenatal, Werribee Mercy Hospital, also to the schools. So really multidisciplinary tele-mentoring. And the Massachusetts Child Psychiatry Access Program is another model that, we don't know if it could work in Victoria, but we need to bring these models, we need to adapt them, and then we need to test them. We need to look at their effectiveness and their cost effectiveness. So it's not an either or, and I think there's different ways to approach this problem, but we've got to change what we're currently doing, because as Professor Coghill said, most children under the age of 12, we have shown, do not get any care, and even if they do get care, it would not be considered minimally adequate treatment based on current best practice to change their mental health trajectories.
That's a good way to give us momentum for the next 5 or so minutes while everybody catches their breath. And why don't I, subject to anything the chair might say, why don't I let you all have 5 minutes and I'll see you then. Professor Hiscock, you spoke so eloquently about your Wyndham project, and you referred in various ways to the improvement of mental health literacy in various people in the health and non-health disciplines, I thought I might recommence by asking you to speak a little further on that topic, both about your Wyndham project and about steps that could be taken to improve mental health literacy, which might be at the heart of the kind of where you're heading on this topic. And then I'll ask Professor Newman about the same issue.
Sure. So the project in Wyndham is part of a Centre for Research Excellence in Childhood Adversity and Associated Mental Health. It's half funded by Beyond Blue and half funded by the National Health and Medical Research Council. 5-year project. We're in year 2. Year 1 has actually been led by Professor Tony Jorm from Melbourne Uni, and he's done an evidence synthesis of what are the impacts of the various adverse childhood experiences on children's anxiety, depression and suicide risk. So he's actually quantified that. And what's of interest, I think, to this panel is that there's a variety of ACEs, adverse childhood experiences, and none of them seem to have a particularly worse outcome. They're all equally bad for children in terms of longer term mental health. So for example, physical abuse or sexual abuse is no worse than neglect. So I think that's important when we think about where we put resources. He's now also done an evidence review of what works to mitigate the effect of adverse childhood experiences on children's mental health. And there's 24 broad areas of intervention, ranging from things we've talked about like parenting, things that build resilience in families, peer-to-peer support, social support, housing support, finance support. So all those really broad determinants that we talked about. And what we're doing with that evidence now is we're taking it to experts across the country, but also to families with experiencing these issues in Wyndham and to the clinicians to say, that's what the evidence says, but what could work in your context? And over the remainder of this year, we're going to develop the model of care that we're going to test at Wyndham to integrate health, social and education sectors to deliver evidence-based care to try and mitigate the effects of adversity. And we're going to explore how best to detect adversity in those families, either through a screening process or less of a formal tick box screen, which is a lot of what happens in the US, because there are those concerns we've talked about with screening. And then we'll be evaluating next year what are the outcomes of this, this model of care on children's mental health, the family's mental health, quality of life, and what are the costs, what are the cost effectiveness of the model as well. And we're also working with Health Justice Australia to put a lawyer into those settings who will actually help families with all the social determinants we've talked about, ranging from fines and housing and employment to more specific matters like family violence. So that's the CRA in childhood adversity, and my colleague John Eastwood is doing a similar model in parallel in Marrickville in New South Wales. So we'll have 2 sites from which to draw upon. And underpinning that work, we're looking at a framework for sustainability and policy change. What needs to happen should this be effective in terms of scaling this up? And we've chosen community health centres deliberately because that's a model of care that's available across Australia. It's not state specific or local government area specific. So, and we're just in conversations now with Wyndham and looking at having a wellbeing coordinator who will have a role of social prescribing for families, as well as care navigation for the more families experiencing more complexity and severity around their life circumstances and their child's mental health and wellbeing. So that's a bit of a watch this space, and it's very exciting, and I think I can see it as a model for, you know, having child and family hubs in the community. But as Professor Coghill talked about, the funding of that's going to be really interesting because a lot of the medical services there would currently be funded through the GPs and paediatricians by Medicare, whereas we have funding for a CAM psychologist to come out and support case-based discussions, tele-mentoring, secondary consultation model for the GPs and paediatricians, and they're funded by the state government. So that's, is that enough on the Wyndham model? Yep. And the next, yeah, and then the next question was around mental health literacy. Literacy, yeah. Yeah. So I think, as Professor Coghill alluded to, we know from the child mental health poll, which was 2,000 parents across Australia, that only a third of parents said that they could recognise when their child had a mental health problem. 2/3 couldn't. The interviews we've done with GPs last year about the mental health system, they said we have real problems knowing when a child's got a mental health problem or not, and knowing when to refer and when not to refer. And I know there is some work being done through BU, which is funded by the federal government, to develop online training modules and resources for early childhood educators and teachers and GPs in this space. I think the challenge will be getting them to take up those resources and use them. I also know that mental health first aid, which is now, born out of Melbourne Uni, is now an international form of training that's been delivered. They're now developing mental health aid for primary school children. I'm sitting on their advisory committee for that. So that's an opportunity as well to better to support teachers and healthcare professionals in particular, not the mental health care professionals, but everyone from the paediatrician or the GP in private land to the second year registrar in endocrinology at the Monash Children's Hospital, whatever it might be, giving them some basic mental health first aid training so they can recognise the early signs of mental health problems in children and know how to respond in the first instance. So they're going through their very rigorous process of developing a mental health first aid course for primary school age children.
Thank you, Professor Newman. One area or one discipline that Professor Hiscock didn't refer to, but you've referred to this area specifically and several times, is maternal and child health nurses. What about mental health literacy support for those important professionals, particularly when it comes to infants?
Yes, look, very important workforce. I'm interested in very similar ideas about integrated multi-professional, multidisciplinary hubs, one-stop shop models for vulnerable families to improve access and equity of service. So I have some funding, philanthropic funding from Helen McPherson Smith to be running a trial of our program, which is Melbourne University and Deakin University, called BEAR, as in teddy bear, Building Early Attachment and Resilience, which is an infant early parenting approach for high-risk, so-called high-risk families, as opposed to generic parenting support. So that covers parents with mental health issues, stressed relationships, and a lot of significant vulnerability. And the idea is, in the same way that Professor Hiscock was talking about with her model, to try and integrate across primary care, paediatrics where that's necessary. A lot of our work is using maternal child health nurses who have got that sort of obviously expertise in infant observation, who go into families and homes anyway, who are very trusted workforce. And I think that's very important for families. And the focus is on engaging these families around being the best parents they can, promoting infant development. So we're trying that as a model in Bendigo, Barwon Health in Geelong, and some very high-risk demographic areas like Corio, where there are very high rates of quite socially excluded families with a lot of drug and alcohol issues and other social problems, very high rates of child protection concerns in an area like that, and high rates of mental health problems. So a nice coalescence of all the things that we're talking about. And we're also going to Mornington Peninsula, where services for the very young are largely run by maternal child health nurses, very limited other services. And the idea really is to build up capacity in these areas. I absolutely agree with the point that Harriet made earlier, that we don't want families with young babies to have to feel they have to keep coming back to a hospital in a major metropolitan centre or a large town for services which they should be able to access quickly and effectively and in a better coordinated way in their area. We're also looking at these models of now using telehealth, obviously, to provide supervision and support and consultancy for families in these areas. And we've rapidly, because of necessity, but it has worked, been running our particular programs around early parenting using Zoom, which has been surprisingly effective, as opposed to having people who are very isolated, have no service. I think that's ultimate, and we're evaluating that at the moment with some other funding. I think what's important is that we evaluate these models We also have to cost them, and I think and look at the potential for upscaling these sorts of interventions. But I absolutely agree that the principles are about improving access, acceptability, but also training and involving a range of service providers who need to be there for families. Now, maternal child health nursing as a group in some of their centres, which I visited now in all of these areas before lockdown, have actually been doing remarkable work in terms of coordinating care for vulnerable families to the extent of having clothing available for those with, who have basic needs, clothing, food collection for those who run low on food, some of the basics of care with other local organisations, and have seen themselves as offering that sort of coordination. So parents, and very often solo parents or very vulnerable parents or parents with mental illness, will actually go there preferentially to other services. And in the absence of having mental health services, let alone child and adolescent mental health services, it's been absolutely imperative. Mornington's a good example of that sort of provision. Somewhere like Barwon Health is obviously better resourced, but paediatricians there are very interested. They have a neurodevelopmental clinic for some very vulnerable infants and children, of having a linked model of early parenting support. And I think that sort of it's a creative process really in some ways at this stage of bringing together these sorts of elements. I think the very important issue is how we evaluate them. What sort of outcomes are we going to look at developmentally in the very young who we engage in programs, and in parents and parents' capacity to deal with sometimes the challenges of parenting and their own stress and so on. And that's what we're doing at the moment. Unfortunately, because of the pandemic, things have been slowed down a bit. We're hopeful that we'll just be doing more via distance in that sphere. So similar sort of models.
Thank you, Professor Coghill. I think you led the charge into the concept of discussing hubs, which is a welcome one because it's a big topic. You have some experience of hubs, but you've also spoken in your statement of the importance of clinical guidelines and pathways, and for that matter, some of your experience in hubs has been, for example, to look at in a different way or treat in a streamed way children presenting with internalising disorders as opposed to externalising disorders and so on. I'm raising there several different facets of this area of discourse, but I wonder if you could speak first to what you observed in the services that worked in that you observed on Tayside, and also to your ideas concerning clinical guidelines and how hubs would function in Victoria, and for that matter, relate to the CAMS and KIMS services.
Yeah, I think the first thing I'd like to say in that is that I agree with all of the discussion we've had on prevention, but it is very important to recognise that even with the best prevention, there are still going to be mental health problems in children. One statistic that we often don't hear, we often hear about 3/4 of mental health disorders that adults suffer starting in adolescence. We often don't hear that 50% of those started in childhood, so before the age of 14. So we need preventative work, but we also need, and that's really where I'll focus in this answer, we need to be able to assess and treat those who present with existing and continuing mental health disorders. It's timely actually that you asked this question, because Professor Newman was talking about the maternal and child health nurses, and one of the biggest differences I found when I moved from the UK or from Scotland to Victoria was that in our service in Scotland, our CAMS service in Scotland, an awful lot, I would go as far as saying most of the frontline face-to-face work was actually conducted by nurses. We had a combination of mental health nurses and paediatric nurses that worked with us, and it was absolutely fascinating to see how this developed over time. what we found was that when we were trying to implement evidence-based care, and we had evidence-based protocols, and I'll come back to them, it was the nurses, not the doctors, that actually implemented them very efficiently. So you asked them to follow a plan, and they followed that plan, but they didn't follow it slavishly. They didn't follow it with a sort of blind, I'm just going to do this and that's my job and I've finished. They followed it with sensitivity, and they followed it up by saying, I've done the bit that I need to do. I've asked you the important questions from my perspective, but is there anything else? What are the other things that are that are troubling you? And they did that and cared about the answers. So we got very good holistic care by including nurses. I think there's been probably both a funding reason why that hasn't happened in Australia, but possibly also a structural reason that that nurses haven't been part of services as they've moved forward. So that's one thing that I experienced. The other was that we had, as I've suggested in my submission, in my evidence, we had a lot of cross-pollination between pediatrics, primary care, and child and adolescent mental health specialists with GPs, we call them gypsies, GPs with special interest, choosing to come to spend time in the CAM service, learning how to assess, how to manage more accurately the types of problems that we see, and then going back out into their general practice. They would maybe come 1 day a week and work in the practice for the other 4. Then going out and not just practicing what they learned, but also training up the other staff around them to work in a creative way with these problems. And likewise with pediatricians, that we managed that in several ways. We would go and join pediatricians in their clinics and do kind of on the job both consultation, case management, and training with them. But also brought pediatricians into the CAM service and had them as an integral part. And that was an interesting experience. I think one of the things we may come to is training. And what we recognized was that our pediatricians had many skills, but they also hadn't had the opportunities to learn how to deliver evidence-based assessments, how to deliver evidence-based care. But what they were able to do, and I think this is the importance of having evidence-based guidelines and evidence-based clinical pathways, they were able to pick up on those and to see how important it was to practice in that evidence-based way rather than not. And I think the lack of evidence-based pathways in Australia is a real lack for us. There are, as Professor Hiscock said earlier, good quality evidence-based pathways, I think particularly from the UK, but also from other countries. They can be adapted, and certainly at the Melbourne Children's Campus, the Royal Children's Hospital and MCRI and the university, we have, as part of our developing mental health strategy, very clear plans to adapt the existing evidence-based pathways to an Australian health system, which of course is somewhat different with that balance between public and private that's not there in the UK. But I think I have no doubt that we'll be successful in doing that, as long as we can get the support to do it, and from that to develop much clearer pathways that will manage a lot of the variability that we currently see. The other one of the other things to come out of the project, the NHMRC project that Professor Hiscock was leading and that I joined shortly after arising, was huge variability in practice. And where there's variability, it's evidence against there being a more evidence-based practice. And I think that we can work on that, but it's going to take time. And as we heard earlier, change is difficult for people. And in order for that change to happen, it's going to need to be supported.
Thank you. Can I ask you about one element of what you observed in Scotland, and that was the difference between what you've described in your statement as the externalising as opposed to internalising disorders, and how they might be approached in streaming generally?
Yes, thank you. Sorry, I'd forgotten you asked that.
It's a very long question.
Externalizing disorders are those disorders like ADHD, like oppositional defiant disorder, like conduct disorder, that mainly manifest in abnormal behaviors. The internalizing disorders include the anxiety disorders and depression, amongst others. And what we found within our service in the UK, and this is a common problem, was that because those adolescents, we had a 0 to 18 service, because those adolescents who were presenting with internalizing disorders and also eating disorders were often suicidal, often seen as high risk, and often seen as needing immediate care, they were prioritized. And their prioritization meant that those with externalizing disorders, so those with neurodevelopmental disorders and more behavioral problems, were always shunted to the back of the list, to the bottom of the list. What we did within our service, and I have to say this was within a service, not a separate service for internalizing and externalizing disorders, because there needs to be a cross-pollination of skills between these streams of work, was that we streamed a internalizing disorders stream and an externalizing disorders stream. The externalizing disorders stream was much more high volume. It involved a lot more medication use, a lot more long-term treatment for chronic problems like ADHD, whereas the internalizing stream involves a lot more psychological therapies, a lot more emergency management of suicidality. It required patients to come into inpatient settings. But by separating these streams and giving each of them their own priority, it meant that we were able to allocate resources appropriately across the two streams. And for those children with the neurodevelopmental disorders whose impairments were actually very considerable, often their problems were not seen as acute, but actually involved complete breakdown of schooling, complete breakdown of families, substance misuse, criminal behaviors. We were able to prioritize those within this group of patients with the externalizing disorders, whilst those with suicidality and other more urgent needs within the internalizing group were also able to get prioritized. And this worked extremely well and actually led to really very much improved outcomes, but also a much greater, more efficient, maybe not greater, a more efficient use of our services than we'd had previously.
Thank you. Professor Hiscock, you've referred in your statement, or at least raised for consideration in your statement, the question whether it might be possible to stream by severity. I wonder if you could outline your views on that topic. You've certainly said clearly there you couldn't stream by age, or you wouldn't want to stream by age. So I don't want to restrict you on the general topic of screening. No to age and why, and possibly severity and why.
Yeah, so I said no to age really, I guess, from my position and experience as a paediatrician where I look after birth to 18 years, and also from the feedback from families. In our qualitative interviews last year, we spoke to 35 families about what's wrong with the mental health system and how to fix it. And I time and time again heard from the families that having to go and tell your story to yet another person or set of professionals was really disruptive, and they really valued continuity of care for their child, and the child valued it as well. Particularly, they would actually disengage from going to yet another service because of an age cutoff, etc. So that's where my feeling, and we don't make kids with diabetes, at the age of 5 go to a different endocrinologist, and then kids with diabetes when they turn 12 go to another person for care of their diabetes. We just don't do that. So I think for the mild to moderate conditions, these should be managed across, the 0 to at least 12, I would say 18, within a service or within the same person ideally. I think when it gets more severe and you need the specialist expertise from a child and adolescent mental health service, then that's ideally when a child may go into that service, but then they come back to the person who's holding them, whether that's the GP, the paediatrician, or the psychologist, would be a way to go forward. So I don't favour streaming by age, but I do favour when things become severe and beyond the scope of the GP, paediatrician, psychologist, then you do need the specialist expertise. And that's why I'm interested in models of care like the telementoring, or like what Professor Newman was talking about, or like the Massachusetts Child Psychiatry Access Program, where we really try and upskill that existing workforce to manage the mild to moderate, which is still the bulk of, by numbers, the number of children who are affected.
Within the more severe or beyond moderate to severe presentations, do you see any benefit in what Professor Coghill suggests concerning separating internalising and externalising?
As long as, and I think Professor Coghill actually said this, the clinicians managing those internalising, externalising streams are skilled in both, because up to 25% of children will have comorbid internalising and externalising disorders at any one time. So that's the child with ADHD and anxiety and a learning difficulty who's now suicidal because of X, Y, and Z. So as long as that's not lost, which I don't think it was, that makes sense.
Professor Coghill, I'll go to you because I can see your hand, but Professor Newman, I haven't forgotten you. I'm coming back.
I just wanted to comment on the severity issue. I think it can become quite complex, because one of the things that we're trying to do, of course, is to treat and manage mental health problems and make them less severe. And if you just select care by severity, you can find people bouncing around between different professionals. So that was really why or one of the reasons why I prefer a hub that includes those who manage cases that are currently mild to moderate, as well as cases that are severe, so that you can work within the same team to be able to manage them appropriately. Certainly, there's times when you will need a more skilled professional to manage someone whose condition worsens. But you want to minimize the movement between different settings. And that really is a big reason, I think, for bringing those settings together. So bringing the CAM services and the pediatric services together within a hub.
Just to be clear about that, your conception of such an approach would be for the hub to include the CAMS or KIN service as well. Is that correct?
Yes,
Thank
I
you.
think so.
Professor Newman.
Thank you. Yes, I just wanted to stress that I think the benefit of the hub approach, as we're discussing it, is precisely that it shifts this discussion about how should we design services from the viewpoint only of the service provider to the viewpoint of families and children who actually access them, which I think, and maybe it's a philosophical point, but I think it's very important that we're actually talking about moving away from artificial barriers of age, or you have to have this number of symptoms to get in here, to really, I think, shifting it to a discussion about streaming according to need. And then that your need on the basis of a comprehensive assessment and with the appropriate multidisciplinary, multi-professional approach should in and of itself guide what sort of access to which services at which level you would be supported by, and then that can be a service, sort of a treatment plan that gets negotiated with families and children as appropriate. That's rather different in terms of how it might function from these the more siloed approach, and I think we probably all agree that we're trying to move away from that. So severity, in and of itself, is obviously important. I mean, even in very young, it might mean that a trauma specialist needs to see a young child who's experienced severe abuse, that has post-traumatic stress disorder, as an example. That can be quite a specialised intervention, might be very necessary. It's treatment for established conditions, and someone might be, very young and have post-traumatic stress disorder. So some severity needs specialist expertise, no matter what discipline that person is. It's a matter of their training, but there's still a whole raft of other people who might help a family where there's been abuse of a child, for example, looking at safety, maintaining safety of the child, and so on, and dealing with a whole range of other professionals. So I think severity is one aspect of it, but I think refocusing the negotiation of treatment and ongoing care to need from the family perspective and the child perspective, I think is very important.
Thank you. Professor Hiscock, back to you. An issue always with any kind of service, and let's accept that a hub in inverted commas is a kind of service in its conception, is always eligibility. In order that the service is not overrun, in order that its pathways function appropriately and so on. How's that being approached in your Wyndham service?
Well, we are deliberately putting our hub into a disadvantaged area. So I think this would not be a model that goes into every single part of the state. So we've chosen that approach. We are actually trying to have a no wrong door approach. So if they do come to the hub, they're not turned away. We are still co-designing what that might look like, but I think we are envisaging that our hub is really about detecting adversity and adverse childhood experiences and responding to them. And we know people might come in with a child with mild problems, moderate problems, severe problems, and still have those adversities in the past or currently. So we're not saying we're only taking severe cases. It is a welcome to all. Everyone is able to come, and we're really about referral pathways, both within the hub but to existing services, because there are a lot of existing services across communities, and we're working very closely with Wyndham Council to map those existing services. But we also then need to do some work to develop what we call those warm relationships, so those disadvantaged families who might need support for housing or might need support for parenting go to the top of the list, not the bottom of the list, which is still an issue, I think. So we are not, our aim is to have it's an open door, it's a one-stop shop, and there won't be criteria that they have to meet to get a service.
And does it follow from what you said? Is one of the reasons for that is that some of the services are actually outside your Wyndham?
Yeah. So yeah, exactly.
And some of those services are other state-based services, so it's child protection and so on. Is that correct?
Yeah. So there's already an alliance in that particular council of early childhood services and family support services, who we've presented to them. So they already have mechanisms. There's the not-for-profit organisations and another number of programs. So they already exist, but they tend to work in silos. So it's about getting them to work together and having agreed upon referral pathways. So I'm sure we're going to come up with those services against some sort of triaging and severity criteria. But then what we hope is that by being in the hub, we can hold those families until they get into that service, because the hub's still got the GPs, the maternal and child health nurses and the paediatricians who are getting monthly case discussion and support from the CAMHS mental health clinician who's coming out to the hubs to provide that support. So I think for some families there will be a holding with their existing health professional before they get into another service.
And just also to be clear about it, it seems to follow from what you said when you introduced this topic that the model that you have implemented or implementing out at Wyndham is not a model that you'd be proposing as to roll out across a state. This is very specifically directed to that local community. Am I right to understand it that way?
Yeah, so it's directed, you know, we chose that community because there's disadvantage, there's a lot of cultural diversity, First Nations families. So I don't see this as a child and family hub in every single suburb or even local government area across Victoria. We would need to go to the you know, target the disadvantaged low socioeconomic areas. That's exactly what we've done. And of course, because this is you know, a pilot and a study and we're co-designing, we've gone in with a council who's very engaged and very interested and have identified, because they're a growth corridor, children and families as a real need to support.
Thank you. Professor Coghill, you mentioned considerably earlier on the difficulties that can arise as a consequence of case management in the system. And Professor Hiscock has just referred to case management necessarily being a part of the operation of a hub of this kind. Can you speak to some of the difficulties attaching to case management?
And I think they may reflect differently on the different purposes. I think Professor Hiscock was saying that the hub that she's got in Wyndham is about managing childhood adversity rather than specifically about managing mental health problems. My discussion in my evidence is an observation that within child and adolescent, child and youth mental health services, an awful lot of the work is taken up in providing case management, which takes away time from direct both assessment and treatment. And I think one of the reasons for this is that the welfare systems within Australia are also extremely fragmented. And so I was used to the social work services, again in the UK, which were always under pressure and were certainly not optimized. But there was always one person. If you had welfare concerns, there was one person to go to. If you had education concerns, there was one person to go to. And a very clear system for who would manage that. That doesn't happen within the children that come to our child and youth mental health services. That case manager role is often the clinician. It's not a role that they've actually been trained to do. They're trained mental health professionals. They are trained in assessment. They are trained in providing therapeutic interventions, but they do. And they do take on these roles of providing the other support that I think could be managed elsewhere. And I think that Professor Hiscock's idea of having hubs that include not just health, but also those who are involved in welfare, those who are able to do the case management, would be a real benefit, because say so much time is lost. This work, I mean, I'm not suggesting that the case management is not worthwhile. It's necessary. But I am suggesting that you don't need to be a clinical psychologist or a trained nurse or a doctor in training, for that matter, to be able to provide this kind of support to children and young people, particularly when that takes away from your role of providing assessments, providing interventions. So yeah, it's an observation, and I think one that's very tough to tackle. I think the funding issue comes in again, because it's always very difficult, isn't it, to get the social work departments to fund something that's going to give benefit to health, or to get education to fund something that's going to get benefits to health. But we need to break down that. We need to see that the health and welfare of our children are so integrated that we need that cross-departmental support that I don't think we always get. But also, I don't know if there's any way to reduce that fragmentation. But when I look at who are the right agencies to provide support for a child's welfare need, then there are usually multiple agencies rather than one that we have to go to, and that duplicates work and also costs an awful lot more.
Thank you. Can I ask you about a particularly intriguing observation in your statement, Professor Coghill, which concerns the approach to the diagnosis of autism, in particular, but neurodevelopmental disorders in this country as opposed to elsewhere?
Not just autism, actually. I think probably it may look like autism, but it's actually the broader neurodevelopmental disorders. And remembering that ADHD is actually the most common neurodevelopmental disorder, probably by 5 or 7 times. And it is, again, very different here from in most other countries. I think it's tradition, I think it's funding, but I also think it's a lack of services provided by mental health for neurodevelopmental disorders to be almost completely the remit of pediatricians, with child and adolescent mental health services having said for a long time, and I think starting to say less now, thankfully, but having said for a long time, these aren't our problems, this is a pediatric problem. The reason it's difficult is that whilst pediatricians have become very skilled at diagnosing ADHD and diagnosing autism, not all of the same pediatricians are as skilled at diagnosing the coexisting mental health problems that go along with a neurodevelopmental disorder, or when they assess them and diagnose them, not always efficient at managing them. Now, partly that's because, again, there's not access to the multidisciplinary team. Whilst medication treatments are the first line treatment for ADHD, ADHD care needs to be integrated within a package of supports. And when you've got a coexisting anxiety disorder or depressive disorder, as is extremely common, then actually it's psychological therapies that are the primary treatment for them, not medication. Also, when you've got intellectual disability and disruptive disorder, then actually a parenting approach or parenting support, a behavioral approach, a non-pharmacological treatment is the treatment of choice there. Again, supported by evidence-based guidelines universally. However, because a lot of the pediatricians find themselves very isolated, they don't have easy access to other mental health staff. It's not always easy either to access psychology, although that can happen. And certainly it's not easy to work as part of that multidisciplinary team. What I've found is a lot more children being prescribed medications for disorders where medication wouldn't be the first line treatment. On the other hand, because child and adolescent mental health services have said, no, this is a pediatric problem, not a child and adolescent mental health service, one of the things I spend a lot of my time doing within our service is working to help CAMS clinicians and KIMS clinicians recognize treatable neurodevelopmental disorders that they've mislabeled as naughty behaviors or as intellectual difficulties. And so the problems go both ways. In most other countries around the world, there's a much more even recognition and sharing of this workload. Certainly, pediatrics, and I'm not suggesting that pediatricians shouldn't be involved in this work. And in fact, I was reminded over the weekend of something that I wrote a few years ago, saying that the let's see if I've written it down here, that the training, experience and availability of professionals is more important than their qualifications. Unfortunately, at the moment, we don't have a balance of training for pediatricians to deal with the broader mental health problems, and for mental health specialists to deal with the neurodevelopmental disorders. And we really need to bring that together. So it's not about it should be one or the other, but people, I think, as Professor Hiscock said, should certainly only be dealing with specialist cases if they've got the specialist training. And at the moment, that's not available, at least adequately available, either within the mental health training or within the pediatric training, in my opinion.
Thank you. Professor Hiscock, you're a paediatrician, but
Yep.
more importantly, you've had your hand up.
Yeah. So I'm just going to give a paediatrician's perspective, because I don't completely agree with Professor Coghill. Certainly, I've done national audits of what do paediatricians see. The number one diagnosis we see is autism. The number two is ADHD. The number three is anxiety. The number four is learning difficulties. And I think coming in at number 8 is asthma. So we see a lot of mental health. I agree that there's been an increase in prescribing of anti-anxiety medications, because we've actually done the audits and looked at that by paediatricians. But as a paediatrician, I can tell you one of the reasons why is when we try and find a psychologist, we can't get one. And Dave will know, we did a secret shopper study last year where we rang 185 psychiatrists, psychologists and paediatricians pretending to be a parent of a child with anxiety to get in to see, and 1/3 of clinicians had closed their books for the year, and that was last April. So already they said, we're not accepting, or they didn't see children under the age of 12 years. So there's a huge workforce issue for particularly psychological support for things like anxiety in children with comorbid ADHD or autism. And even if we can get a family in, the average out-of-pocket cost for one consultation with a psychologist is $84. That's the average, so there's a big range. And many families, that's after the Medicare rebate, so many families will come to me and say, I can't keep seeing the psychologist fortnightly for my child. I know they need that. The school counsellor will give us 3 sessions, that's it. I've had my 5 or 6 sessions Medicare refunded, but the $84 out-of-pocket cost is stopping me going any further. So that's a big problem. And I think then paediatricians then to turn around and prescribe medication because they feel like there's no alternative available, and we can't get them into the CAM services because they're not severe enough.
Thank you. Professor Coghill, back to you.
Yeah, I mean, I don't disagree with what Professor Hiscock's saying. However, my point really was that professionals who are managing these cases, and they certainly have the experience, but they often don't have the training. Training and experience aren't the same thing. You know, and there's a reason why it took 5 years to train to be a child and adolescent mental health or psychiatrist, and you know, within that training, there's an awful lot that one learns. I think that we don't give enough training, and it's not because people don't want it, it's that we don't give it. We don't give enough training to our pediatricians, many of whom, when they finish their training, will say, gosh, I've got to deal with all this mental health problem, but no one's trained me to do that. I never received the training. I get lots of experience, and for me, that's a problem. It's about having the training as well as the experience, and certainly Professor Hiscock's 100% right when she talks about the availability. It's not anyone, it's not the clinicians who are seeing these cases problem that they can't find people. It's because they aren't there. But if we want, and I'm very supportive of this, if we want a pediatric workforce working in specialist mental health, then we have to provide them the training. There isn't a shortcut to that. Just experience won't cut it. And I think that that's a very important, important point. So no criticism of pediatricians. It's just that that's not the way things are structured at the moment. People do 6 months within a CAM service or a behavioral pediatric service, and then go out and manage and struggle to manage because they're not supported. So I'm not critical of those paediatricians. I'm critical of the fact that we don't offer that support and training. And that's why I think a hub that links in paediatric and specialist mental health services, because that's how you provide some of that education. You don't need to work in it for 5 days a week. You can work in it for a period of time to get that experience, get that support, and get that access to services, and then be able to work in other settings more independently. So I don't think we really disagree, and it certainly isn't a swipe at paediatricians, and also remembering that I'm also very critical of my own profession in not having got itself the correct training for what it ought to be doing in the neurodevelopmental disorders.
Thank you. Professor Newman, at least on my screen, you've been positioned as if you were the net court umpire while that rally's been going back and forth between your colleagues. Can I move to, or ask you to introduce and address a slightly different issue, which is much of what's been said so far today has addressed and identified issues of fragmentation in the provision of services, both clinical and other. And it's also identified the need for integration, which is a point that every witness has made at different times. You, in your statement, refer to the need for statewide or state-level planning. Could I ask you to speak to that issue?
Yes, certainly. Look, I think it's fairly clear that we all agree about the problems of fragmentation and a lack of a coherent framework for thinking about service modelling, service development, and the related areas, training and education, as is being discussed, and research, that we can actually start to evaluate our models and so on, which is very important. Now, currently, we don't have a statewide planning process, even in the most rudimentary sense. I've not been in Victoria for many years, but since I've been here, I've seen the dissolution, for reasons that I'm not privy to, of what used to be the maternal and perinatal planning process, much wider committees for looking at child and adolescent service development. We used to have, I guess, more of a presence of a child psychiatrist in the Centre for Mental Health, in the department, and so on, which maybe has just been the way things have shifted over a relatively short period of time, but that certainly hasn't helped in terms of having any centralised meeting places, really, where we can have creative discussion about some of these ideas in the way that I think we all benefit from, let alone translation into policy approaches, development and evidence base, and outcome evaluation. I think very importantly, we need some centralised and very comprehensive modelling of who's doing what to whom, that sort of notion, and with what benefit to children and families. And that's certainly the approach, my experience in the UK, that's been very important there, that you've had the development of, and constant review of different approaches. There's still diversity of opinion and different approaches, but there was if you like, a clearinghouse, much more of a clearinghouse sort of process that integrated early childhood right through, and that's been, I'm referring there to Peter Fonagy's work and others, which was very important in that context, and really had that sort of expert consultancy role for government in thinking about, well, how should we be modelling these services? I think at the moment we, to put it rather crudely, but we've got a bit of a sort of a gulf. There are, those of us who do this sort of work, we're doing our own, trying to do research, trying to feed into something, but it's not clear where we take the results and evidence to, and how that gets translated in a policy context. So I think David raised the issue in previous discussions about how could we have a centralised or an approach which is a body to actually look at these crucial elements of service modelling and development, the development of clinical guidelines, collecting and monitoring evidence about infant, child and adolescent services in a way that some of the other mental health areas and different age groups are probably going to have. So currently we don't have that. I also think it's, from my perspective, I think very important that we look at that in a broad way so that it does include providers of, from my age group perspective, all those who work with the very young, and other components of the service system, in the same way that we've been talking about the importance of primary care and paediatrics and so on, to bring those bodies together to actually talk about developing frameworks. So we've all got, there's a lot of thinking obviously goes on into ideas about how things might be improved. We don't actually have mechanisms other than on local levels to influence government in that discussion.
Thank you. Professor Coghill, I'll go to you on this topic and then I'll finish for my part with Professor Hiscock on this and any other topic. But Professor Coghill, you've referred to this need for coordination in your own statement, and Professor Newman's made reference to your views on this topic. Could you expand a little further, and also with observations concerning the approach that's been taken in the UK that's been referred to?
Yeah, I was, I'd have to say thank you to the commissioners for this, because I was really taken by and impressed with your proposal for a collaborative centre for mental health in the first part of your report. When reading that, it really, and thinking about the questions that we were asked, I think it's really necessary that we have something similar that addresses the needs of children. I think the only question I have in my mind is how many centres, collaborative centres, can one have? You've highlighted one for adults. We already have Origin, who serves this purpose for the youth mental health space, but it's very clear to me that with the best will in the world, Origin can't fill that space for the 0 to 12. So I'm left with the conclusion that we do need one specifically at this. I think the roles of that will be, I think, ensuring participation and promoting co-design. I loved the proposal that you had for the centre, collaborative centre, to be led jointly by an academic and someone with lived experience. I guess we're not going to be asking children to run this, but I think that involving those with lived experience and consumers of mental health services is really important, that we can get participation right, that we can provide that strategic leadership that Professor Newman is pointing out, and that the Vargo report was very clearly saying hasn't been there in child and adolescent mental health. To conduct research into new treatments, translational research, to inform service delivery, to be able to promote, design, and test new models of care like the ones that Professor Hiscock has alluded to, and also to be a focus for education and training across the broad mental health workforce. And I think, again, those two are separate from each other, education and training, but we would need then to be very strongly linked with the Royal Colleges, with the other educational providers. We have Mindful already, but I think at the moment, again, that's a bit disparate. So I think that's something that should be a key focus. I've had the opportunity in the UK to work with centres like the Institute of Psychiatry at King's College, which has a very strong academic centre for child and adolescent mental health, but very clearly embedded into the Maudsley Hospital. Likewise, my colleagues, again, very close colleagues that I've worked with at the Central Institute for Mental Health in Mannheim in Germany, a big, very strong academic mental health present, but embedded within or with a clinical service embedded around it. We don't really have that model here yet. We don't have the strength. We have good researchers, we have good clinicians, but often not working together as effectively. And likewise, the Donders Institute and Character in Nijmegen in the Netherlands, exactly that same model, integrating academia with clinical work. What they don't do as well, and I think what we have the opportunity to be, I guess, world leading on, would be to have that, but also have that effective participation from a very early stage and at all levels of consumers, of users, and be able to get that voice in much more clearly. So really, I was spurred on in thinking about this by your recommendations for the Adult Collaborative Centre. But I think it's hugely important if we're really going to take child and infant mental health seriously, that we have something like this. I think our campus may have already written to the commissioners to say that it would be very interested in either taking a lead or very much being a part in that. And I think that's very sensible. But I think it's something that would need to very clearly be thought through and worked through in a clear and equitable way that made sure that that it was representative and that it was excellent, because that needs to be excellent.
Thank you. Professor Hiscock, I'm as good as my word. Can I finish off by asking you for your thoughts concerning how best issues of fragmentation, integration and planning, for that matter, and also the translational research might best be addressed in order to make the system work for infants and children in Victoria?
Small question, thank you. Look, I think
you've only got 3 minutes.
Great,
so here you go.
I like time. I think this collaborative centre is essential, and I think Professor Newman talking about translation into policy is key, as well as what Professor Coghill has said. Otherwise, we just risk on the status quo, which is good pockets of excellent research and practice happening in silos, duplication, left hand doesn't know what the right hand is doing. Some excellent things come out, but they don't land on fertile ground because there's no government lever to make it happen. I see hubs as the way to go that address children and families and social determinants, that bring together that specialist mental health care to that primary and secondary care workforce. But I think this idea of an overarching collaborative centre that really has strategic overview and leadership, is truly multidisciplinary, brings in the lived experience, sets the priorities and framework for the next 5-10 years for this state. It's a really exciting opportunity to take the fragmentation and silo we have now and just turn it into something fabulous. And as Professor Coghill alluded to, we're doing a microcosm of this with a 5-year campus mental health strategy that I'm leading. So all of this just sounds like what I've been living and breathing for the last 4 or 5 or 6 months. But to do this at a statewide scale would place Victoria streets ahead of the other states in the country as well, and really internationally leading potentially.
Thank you. And thank you to all of you for your contributions so far. Our commissioners have sat very patiently and quietly listening so far, but they have questions, I assure you. So at this point, I can invite the chair perhaps to take the reins, but I'd like to thank each of you for your contributions so far.
Thank you, Stephen.
Likewise, thank you all very much. It was a fabulous session to participate in and hear what gives extra impetus in terms of your witness statements and the details that you each individually had in them, to hear what your collective thoughts are. And there are many, many issues that this conversation has raised for me, and I'm sure all of the other commissioners. There's one issue I want to just follow up with Professor Newman, which went to, you talked in your witness statement about the fact that, that there's an impact on women, and and infants by the fact that the Royal Women's Hospital has not been gazetted as a recognised mental health service under the Act. What do you think are the implications for that, and what opportunities are there for us to make reform in relation to the role it might play in terms of infant and maternal health?
Yes, look, it certainly is a significant issue, is that it, in that although the hospital does a reasonable amount of both acute and ongoing mental health work, and all the themes that I raised about the opportunities for early risk identification, prevention and early intervention are really all there, but because of lack of constitution of that service as a mental health service, there's really maybe under recognition, and certainly that diminishes the actual capacity for service provision, although there is a mental health team there. I should say that I've recently resigned from that position, so I can't comment on what developments will be there in the future. But I think in general, the maternity hospitals, not just the women's, but all the hospitals, are in an ideal position to be doing some of this work. And importantly for the women who are having mental health problems either during pregnancy or post-delivery, the whole implication of having to move women out of a maternity setting into another environment can be very disruptive to care. It's not necessarily in their best interests, and it sets up all sorts of major demarcation issues between mental health services and maternity services, and that's a constant issue. So on one level, it's a governance issue, but on the other level, I think. My personal view is that it's it diminishes the importance of women's mental health and where we should be providing that. I think it's not only maternity, but that's an ideal place to be providing that level of care. So a source of disappointment that hasn't been addressed.
Thank you. And then just one other question. I was particularly struck by that data that you gave, Professor Coghill, about the fact that the 12,000 children seen by CAMS had on average 30 episodes or incidents of care, but very little of that was directed towards evidence-based therapies. I guess I was pretty struck by that, and I want to be clear on whether the evidence-based therapies are available, who should deliver them, and where, in your view, are we best placed to try and address that going forward?
Okay, so the data relates to the numbers of individuals seen. It's my observation, not within the VARGO data, that much of that time is spent in case management rather than in the delivery of evidence-based care. Evidence-based care is available, but not structured. So across Victoria, we have very little in the way of ensuring that the care that is delivered in an evidence-based way. We don't measure meaningful outcomes to look at both how care is delivered, but also what the outcomes of that care are. The reality is, though, that it gets crowded out by this case management that has to be done. And when you talk to staff within the services and you ask them, why is it not possible to provide cognitive behavioral therapy, for example, for this young person? It's because their life is too chaotic and I have to spend all of my time actually managing their expectations and the family's expectations. Having said that, whilst evidence-based care is available, the training in evidence-based care isn't prioritized, particularly for psychological therapies. Again, most staff will need to pay for their, or many staff will need to pay for their own training in psychological therapies. Psychologists are trained, that's part of their training. Psychiatrists receive some training, and some psychiatrists top that up and receive a lot more. I was very fortunate to have received training across a range of psychological therapies, but many staff don't, and there's not training, there's not funding within the budgets to provide that specific training. And that again is where I see the collaborative centre as being hugely important. The other problem hidden within these services, I have mentioned it in my evidence, is that most, apart from the consultants, the medical consultants, most staff within CAMS services work within generic roles. So you'll find a psychologist whose job title isn't clinical psychologist, but mental health worker. You'll find a nurse who has exactly the same job title and is expected to do exactly the same work. So not everybody is trained in all of the therapies, and it then becomes very difficult to move patients between one caseworker and another in order to get them to the person who has that training. So there are multiple causes for this happening. That the casework is one, but there are other logistical issues that again are different here from my previous expectations. I think some of these should be easy to fix, but we need the leadership to do that. We need the direction to do that. And we need the services all pulling in the same direction, not working in isolation to very different strategies and strategic plans. I hope that answers your question.
It does. Thank you very much. Can I just then ask finally, Professor Hiscock, do you think those sort of evidence-based therapies will be able to be delivered in your Wyndham pilot, for example?
Yeah, well, we're certainly hoping for that, and that's part of what the evidence synthesis is about, and then presenting that evidence synthesis back to the clinicians on the ground and to the families to say what version of this can we make work. So that's what we'll be aiming to do as part of our intervention, along with the case discussions and the secondary consultation model, and bringing all those different sectors together.
I know that Dr. Cockram will have some issues, so Dr. Cockram, do you want to put a question to the panel?
Yes, so many questions, and I'll have to contain myself a little. I think I'm going to stay on this hub discussion because I think you've raised a significant thought process within the Commission. So on one hand, we've got Professor Hiscock recommending or trialling a primary and secondary care model with some embedding of the tertiary specialist system within it. And on the other hand, Professor Coghill's talking about a more tertiary model with the embedding of the primary and secondary up into the tertiary. I guess, Professor Hiscock, I'm going to put the question back to you. In your model, you require a specialist system because you've talked about the need to have the CAMS clinicians and other people coming to the primary centre. Is there a model where both fit in, that there is a regional specialist service that can embed itself and maintain its own clinical practice and specialisation while supporting these primary care centres? And because I don't think your system works without the specialist, but if we don't consider the specialist, then where does it go? It becomes something that then loses emphasis in the system and is at risk. So is there a combination we're talking about here to keep that whole ecosystem going?
Yes, and I think telehealth and telementoring provides a way of doing that. I think neither of these models has been fully trialled and tested in Victoria. So you're getting opinion, not evidence at the moment, which is really important to be aware of. And I think if we take any or both forward, they need to be evaluated for effectiveness and cost effectiveness. So that's my first point. And then I think one of the big issues is I've worked quite a lot with GPs. some GPs will be, as Professor Coghill called, gypsies and go into a tertiary centre and get that experience. A lot of GPs, they're running small businesses. They will not go in and participate in day-long training, etc., in another area that takes them away from practice they work in, where they can only bill certain percent of what they see through Medicare and have to give the rest of the money to operating the practice. So we actually need to go out to them, which is what can happen in a community health model, because the GPs are already co-located at the community health centre. And I think...
Sorry, just to confirm though, your model does still require a specialist response. It's
coming
not a
out,
primary
yes.
care response.
Correct. So in the centre already are GPs and maternal child health nurses and paediatricians. What we're trialling is bringing a CAM psychologist out to the centre for, say, 3 or 4 sessions per week to do some direct care, but also some secondary consultation with those GPs and paediatricians and maternal child health nurses to say, okay, tell us about patients you're having problems with and difficulties with. Let's work on how we can help and support those families and help you to support those families. So, and RCH CAMS has, as part of the model, has made, we've got funding to bring a psychologist out to that centre. So they do a lot of outreach, as do many CAMS services already, reaching out into other community service settings. And this is an example of that, but bringing the social care in and the lawyer in as well.
Thank you. Penny, can I ask just one more? It's again back to you, Professor Hiscock. You mentioned that the daunting 24 interventions that are possible, and it's a biggish number, but you've actually put it back to the local community in a place-based way to say, what do the people of Wyndham and the clinicians of Wyndham think would be most helpful? Just talk a little bit more about that model where you're getting, although you've got a kind of a potential for a statewide scale, you're also requiring a local-based co-design approach, because I think that's also really interesting.
Yeah, I think it's essential. Otherwise, you won't get uptake and implementation. If you just come and thrust in and say to people, this is what you have to do, it's not going to work. So this co-design process is happening towards the end of this year. It's been delayed by COVID and into next year. So October, November, December is our co-design process. And that's bringing in the Wyndham City Council, the Community Health Centre, which is IPC Health, who've got a number of community centres. We're going to Wyndham Vale, the clinicians and the families with the lived experience. So it'll be, we have some fixed elements. We've got some ideas of what we think should be in the model of care, but there'll be flexible elements that they can help with the co-design. And they're also going to help co-design our outcome measures for the hub as well. And I think this just has to be place-based, considering the cultural diversity in certain areas. Rural areas will have different needs to metropolitan areas, etc. So we're adopting the co-design approach, which sits very well with IPC Health and the Wyndham City Council. And I think that's going to maximise uptake of our hub model.
Thank you.
Thank you. Just one follow-on before I hand over and ask Professor Fels and Professor McSherry their questions. Just in terms of co-design, Professor Hiscock, can you ask children to have input into co-design under the age of 12? So can you just speak to that issue? Because I think often people just presume it has to be the families, the carers. What about children themselves?
Yep. You can absolutely ask children themselves. They will really, I think as young as 5 or 6, have pretty clear ideas on what they have found helpful and not helpful, and what makes them feel welcomed and not welcomed into a service. So there's some aspects around that they can certainly do. I mean, I see children of all ages, and if a child of mine's seen a psychologist, I'll say, so what does she talk to you about? What have you done? What have you found helpful? And they can pretty much tell me, I thought it was a waste of time, or she gave me all these things like breathing exercises and things to do. And when I get sick in my tummy, I start to use those and they help. So absolutely, and they can inform co-design.
Thank you very much. Professor Fels.
Well, first of all, thank you all 3 witnesses for your very excellent written statements, and also for today. It's been most informative, and I must say I've often been exposed to expositions about mental health that put a huge emphasis on adolescence, and we hear much less about child and infant. And incidentally, I would be interested if Professor Coghill could send us that, was it 50% figure that he quoted as a bit of a source of authority on the importance of early childhood. Now, on my questions, I just had a couple of general questions. Maybe to Professor Hiscock, because could you tell us a little bit about family and carer involvement? It seems to me the sector is quite good at that, and that's natural. But what are the real lessons, secrets, methods? And I'm asking that because the rest of the mental health system is not very good often at engaging with families. So what can we learn? And then my other question, which I thought I'd ask is, what are your big asks? I asked this of the three witnesses, although Professor Hiscock, I think, was pretty clear in her closing statement. I mean, we've heard, we need leadership, strategic thinking, we need to deal with underinvestment, prevent siloing, more prioritisation, and I agree with all that. And hopefully our commission will try to give some direction and priority to this area. And also I think there's a fair bit of support for the collaborative centre concept. So putting that to one side, what are the most urgent things to spend money on? What are the most urgent most important ask out of the big list in our resource-constrained world? And as I said, we heard a fair bit from Professor Hiscock in her wrapping up, so maybe particularly the other two.
Thank you, Professor Fels. I'll start with the issue about engaging families and how to do that well. I think that's part and parcel of infant and child mental health and health professionals who work with families. That's sort of our core bread and butter, because we have to engage families to get anywhere with any of our treatments and interventions, because it's mostly through the parents that we and the caregivers or the extended family who look after that child that we make most of our difference. So I guess that depends. It comes back, there's formal training programs and that, like the family partnership training that comes out of the US, or versions of that are shorter, because it's a 5-day training program. But the Centre for Community Child Health, where I work, runs training in that for health professionals on how to engage families. So that exists already. I think we naturally will ask about what the parents' expectations and goals are and how can we help them, those simple sort of questions to engage families. However, in my interviews with families about what they thought was missing was funded Medicare redebatable family therapy. So often they recognised the child came with a problem and that the parents were in conflict about how to manage that and how to follow through on therapy that was recommended. And they realised that family therapy was necessary. So we don't have a lot of publicly funded family therapy available in Victoria at all. And that's a gap, I think. In terms of my big asks, sorry, I felt like I was wrapping up an NHMRC fellowship interview when I finished off, but I think it's the big and urgent is, I do think we need this collaborative centre that has, so any of our work has a place to land and some fertile soil to land on. I think we do need to look at models that bring together primary, secondary and tertiary healthcare and social care. Now, that's not going to be done in a couple of months. That's going to be done in some time. But I think that's a big ask. I think the clinical practice guidelines and care pathways that Professor Coghill talked about are a big ask. We have statewide guidelines out of the Royal Children's Hospital for physical health problems. They are statewide. They've been taken up by New South Wales and Queensland because of their utility and need, but we have no comparative statewide guidelines for children's mental health or infant mental health. So that's a big ask, I think, that we need as well. So I think for me, it's the integrated models, hub models, and development and testing of those. It's having a place that we can, or an authorising environment where we can bring our evidence into practice and policy, and that really would be the collaborative centre that government listens to and responds to. And then the third thing would be the clinical practice guidelines that then inform the models of care.
Thank you.
Thank you. And I might, Professor McSherry, if we hand over to you to ask your question, and then if we've got time at the end, we might ask the other two panel members what they would prioritise for the big spend. But Professor McSherry.
Yes, thank you. This is for Professor Newman, but I think Professor Hiscock might also want to comment. Professor Newman, you mentioned before the importance of trust in services. We've heard from various community groups, and in particular members of Aboriginal communities, about the avoidance of going to mental health services for fear their children will be taken away. So how would you go about building either culturally responsive services or culturally specific services? Is there a need for both?
There might well be a need for both, but I absolutely agree. It's a huge issue, and particularly in sort of services that I've been involved with, and in maternity services, where you often get that limited access to Indigenous health workers, Indigenous maternity services. Where those are in place, usually in regional centres, they are actually utilised really well. But then if anyone has pregnancy or birth complications and they come to a major hospital, where they might not get access to culturally specific and appropriate care. And I think that immediately sets up poor relationships. And people are understandably very reluctant to engage in that way, and we have some women self-discharging, against advice, these sorts of adversarial type of situations. And child protection services are sometimes not seen as being able to engage or talk about some of the reality facing women in their particular context. So how do we unpack that and actually move towards it? I think where we do have Indigenous midwives and Indigenous trauma-informed services, they can be particularly effective. So I'm thinking of largely the work that you may be familiar with, that Kath Chamberlain and others are doing. I'm involved in that. Looking at trauma-informed maternity and early childhood services in Indigenous centres, using Indigenous health workers and others on the ground to actually establish those relationships. Now that's a long-term project, but I think it's particularly important as a model. I think just throwing a couple of people in a maternity setting doesn't make much difference to that.
Thank you. And Professor Hiscock, I know you mentioned culturally and linguistically diverse groups in your statement, and particularly in relation to screening or surveillance, that might mean different concepts to different groups. How do you go about making sure that services are culturally responsive?
Well, I think so I'm just thinking of a couple of examples. At Monash Children's, they have a First Nations child health clinic, and what they found was kids weren't turning up. So they had one of their Aboriginal workers go out to families and do a home visit. And after that first home visit, their failed to attend rate plummeted in the service. So was that initial warm referral, trusted health professional, someone from their culture coming out. Similarly, at the Royal Children's, we have Wodja, it was the Aboriginal Health Service. They make contact with every, First Nations family who comes through the hospital, and they do a lot of work around mental health. They may not necessarily call it that, but that's what they do. But that's philanthropically funded, and that's not funded out of any core operating hospital funds, which I think is less than ideal. And then I would just say Dr. Anita DePrano, for her PhD, has done a cultural adaptation of some of the key mental health screening tools for children. So there are some really good mental health measures around for children that have been particularly adapted for and tested in First Nations populations. So we do have some of those tools available, and it is possible, and she's done that work through her PhD and found it to be feasible and acceptable to administer those sorts of screening measures to Aboriginal families.
Thank you.
Also some very good work going on in both Northern Territories and South Australia with outreach into the very remote communities there, and I've certainly seen feedback from that looks very positive. One of the problems we have, I think, with Aboriginal and Torres Strait Islanders with mental health is actually a very poor understanding of their understanding of what poor mental health is and what it means. I'm obviously very new to the country, but understanding, for example, what ADHD means within an Indigenous community is something that we really just don't have. So I think alongside a lot of the great ideas and work, it is also very important that we commission research to properly understand that cultural meaning, because there's often my first sort of involvement was where there's a big culture clash between those disorders where we recognize a strong genetic background with the cultural beliefs and belief that many of the, if not all of these disorders are related to trauma and intergenerational trauma. So actually squaring that circle of understanding, I think will be very important, and that will take research and funding.
So thank you all very much for your time. Professor Newman, is there anything you'd want to add to that list of priorities as we...
I think the list we heard was a very good list. I would only add one wish, that in all this thinking that's going on is that we try as much as possible to maintain a focus on prevention and early in life intervention. That's not... I mean, yes, we need to have the leadership and the strategy and the input into policy to actually develop things, but we need a philosophical, if you like, an overarching framework that allows us to think developmentally, as we've all been discussing, to maintain that as a way of looking at service development, but also to look at integrating ideas about prevention and early intervention, and that means from the beginning of life, if not before. So I think rather than silo off early infancy and pregnancy care services, I'd be much more comfortable if we could look at the overlap issues and actually really stick to this idea of integration.
Fantastic. Yeah, I've gone on mute. Thank you all again very much for your time with us today, and to Counsel Assisting, most especially thank you for bringing so much depth to the discussion that we'd like to ask. And do you want to add final word, Stephen, before we finish up?
I don't seem to be able to unmute this thing very easily every time I go looking for it, but I really would like to thank everybody. The commissioners have undoubtedly, and they've said it, been tremendously assisted by all of our panel members today. It's been a thoroughly stimulating and enjoyable panel, and those who get to view this on the Commission's website, I'm sure will be rewarded for the experience. So I'd like to thank all of you.
Thank you very much.
Thanks for the opportunity.
We will give great thought to your input, so thank you all very much for helping us in our task.